Hi, everyone. I'm Tian Zhang. I'm a GU medical oncologist at UT Southwestern Simmons Comprehensive Cancer Center in Dallas, Texas. And today I'm really glad to be doing some of the highlights from ASCO 2026 with the Springer Medicine platform. At ASCO this year, we saw some really interesting results on the kidney cancer front. The results of RAMPART, which was a phase 3 trial. It was an investigator-led trial out of the UK that randomized patients to 3 cohorts, either durvalumab, tremelimumab, durvalumab monotherapy, or active surveillance in patients who had resected high-risk kidney cancer. Of note, the combination of durvalumab and tremelimumab was covered at GU ASCO this year, and these were the first results of the durvalumab monotherapy cohort. In that cohort, 225 patients were treated. Most of these patients had clear cell, although they had about 16% of these patients who had non-clear cell kidney cancers, and about 4% of them were M1 NED after metastacectomy. Of those patients, they saw a 3-year disease-free survival, around 78% for patients who received that 1 year of durvalumab monotherapy. And this was compared against 72% in those patients who had active disease surveillance with a median follow-up of about 3.5 years. The monotherapy didn't perform too differently from the combination, which we had seen earlier that this year, 3-year disease-free survival, about 80%. Of note, in the adjuvant setting, we also saw some of the first circulating tumor DNA discussions, and this was a ctDNA analysis that was performed of the KEYNOTE-564 trial. As our colleagues know around the country, KEYNOTE-564 was the registrational trial for adjuvant pembrolizumab compared against placebo for high-risk resected renal cell carcinoma. And we saw the results of circulating tumor DNA analyses, the first, I think, biomarker analyses of KEYNOTE-564. Of the patients who received ctDNA status, there on this particular detection, there was both 16-plex and 64-plex ctDNA detection platforms used. 64-plex platform performed a little bit more sensitively, but what we saw was that overall there were still low rates of ctDNA positivity in this population, about 30 patients in each of the cohorts, less than 10% had ctDNA positive disease. And when patients did have ctDNA positive disease, they had poorer survival and also a benefit of disease-free survival compared against placebo. Interestingly enough, this is the first clinical use of ctDNA that was applied to a phase 3 trial in kidney cancer. And even though the sensitivity is low, the specificity is quite high. So I can say when people do have their Signatera assay sent from kidney cancer, if it is positive, it is a harbinger of poorer risk disease and perhaps micrometastatic disease, where we should be intensifying treatments. The final abstract I'll highlight from ASCO this year was the RADICAL trial. RADICAL was a phase 2 trial that was run in the Alliance Cooperative Group here in the US. This trial was really looking at bone metastatic disease and kidney cancer and randomizing patients to either cabozantinib alone or cabozantinib with radium-223. This is an alpha-emitting radiopharmaceutical agent that we use in prostate cancer quite routinely, and trying to improve on symptomatic skeletal events as well as other disease-related endpoints such as progression-free survival and overall survival. Of note, the study did close early because of a futility analysis. There were about 48 patients randomized to the combination of radium with cabozantinib, 50 patients randomized to the cabozantinib cohort, and we did not see an improvement in symptomatic skeletal events between the two cohorts that were treated. And so the hazard ratio was above 1.24, and because it crossed the futility threshold, the Data Safety Monitoring Board recommended study closure. However, it is the first time that radiopharmaceutical was used in our NCTN patient populations across the US. And so I do think it's important that the trial was able to be carried out. And we are still searching, I would say, for the ideal treatment for metastatic disease and kidney cancers. But certainly adding in the bone sparing agents and considering all of our systemic agents in totality is important for these patients.